What is the criteria for diagnosis of abdominal pregnancy? Abdominal pregnancy is the rarest pregnancy. Study Ford criteria. Palman's criteria is ectopic in cervix, which has hourglass appearance of uterus. Spielberg criteria, ectopic pregnancy in ovary. Rubens criteria, this is also ectopic pregnancy in cervix. Ectopic pregnancy. The incidence rate is 1 to 2%. With artificial reproduction therapy is 5%. After one ectopic pregnancy, there is chance of 15% of reoccurrence. After two ectopics, there is 30% chance of reoccurrence. Etiology: pelvic inflammatory disease. Previous ectopic pregnancy, history of infertility treatment, intrauterine contraceptive device, progesterone only pills, history of tubal surgery, history of endometriosis and TB. Most common site tube. Most common site in tube ampulla. Ampulla ante this is the spot. This is ampulla area. It is the most common site. Time of rupture happens in ampulla only at 6 to 8 weeks. Isthmus, which is the next part of the ampulla, it takes 4 to 6 weeks. Cornual or interstitial, it takes 12 to 16 weeks. That is almost intramural portion లో మాట. Cornual అంటే ఇక్కడ intramural. Fate of ectopic. Intramural అంటే ఇది. Fate of ectopic. Ectopic has its own syncytial rhodoblast. HCG. Corpus luteum survives and gives progesterone, maintains pregnancy and endometrium. Most common vascular insufficiency. This vascular bleeding due to shedding of testicular gas. Tubal abortion, second most common. Rupture of tube. Because of vascular insufficiency, blood తక్కువ అయ్యి there will be abortion of ectopic. And the tubal abortion is the second most common due to rupture of tube. Presentation most common. Pain than vaginal bleeding. Syncopal letters, classical presentation. Signs: shock, hemoperitoneum, Cullen sign, periumbilical bruising, Turner sign, flank bruising. So Cullen sign అంటే Cullen sign is umbilical area. అంబలికల్ ఏరియాకి చుట్టూ బ్రూజింగ్ ఉంటుంది. ఇట్స్ ఫ్లాంక్ బ్రూజింగ్ అంటే సైడ్స్. ఇది అంబలికస్ చుట్టూ బ్రూజింగ్ ఈజ్ కలెన్ సైన్. నడుం దగ్గర ఉండేది ఫ్లాంక్ సైన్. అండ్ దెర్ విల్ బి అబ్డామినల్ డిస్టెన్షన్ ఆల్సో. Management: resuscitation plus planned surgery. Ruptured ectopic pregnancy, laparotomy, laparoscopy should be done in stable patient, not in shock patient. Surgical methods: total salpingectomy. In case of ruptured ectopic with profuse bleeding, never do partial or segmental salpingectomy. Rupture అయిన ఏ ectopic pregnancyలో should never leave both the fallopian tubes. So total salpingectomy. Linear salpingectomy can be done for conservation of tube in case of Unruptured ectopic, preferred in young patients desiring of bearing child. Resection and reanastomosis of tube. Tube conservation in case of unruptured ectopic. Medical management. Sorry, linear salpingostomy. Conservation of tube and salpingostomy and conservation of tube is done only in unruptured ectopic. Resection and venous tube conservation in case of unruptured ectopic. Medical management for unruptured ectopic. Methotrexate, actinomycin, potassium chloride injection. In medical management, HCG less than 5,000 international units. Sac size is less than 3.5 to 4 centimeters. And cardiac activity is nil. Surgical more than 5,000 international units. Sac size more than 3.5 to 4 centimeters. Cardiac activity present. Early diagnosis. Transvaginal sonography. Look for ectopic gestational sac. In transvaginal sonography, we can see ectopic sac 1 week prior to transabdominal sonography. Discriminatory zone. Transvaginal sonography. More than 1,500 international units. Gestational sac would be in 5th week. Cardiac activity in 6th week. Transabdominal sonography. More than 6,500 international units. Gestational sac is seen in 6th week. Cardiac activity is seen in 7th week. Serum beta HCG. Normal pregnancy lo doubles in 2 days. Ectopic pregnancy lo doubles in 5 to 7 days. In serum progesterone. In normal pregnancy, more than 25 nanogram per deciliter. In ectopic pregnancy, less than 5 nanogram per deciliter. Missed abortion, less than 5 nanogram per deciliter. Important, ectopic pregnancy can be abdominal, rarest ovarian and the cervix. Abdominal pregnancy may go up till full term. It is the rarest form. Management. If present at term, laparotomy to deliver baby. If placenta is stuck to posterior abdominal wall, leave it in situ and give methotrexate and actinomycin post-operatively for placental degeneration.